So thank you very much for the introduction. I tried to keep my presentation short to allow the break afterwards. This is going to be about PEEP and NAVA. Now the results of what I'm presenting have been published in CHEST 2 years ago, and the main work has been performed by a fellow named Christina Passard, again in the University of Bern, Department of Intensive Care Medicine. We talked a lot about outcome studies yesterday and today. We just thought before we move on to perform outcome studies, we should actually understand the knobs which are available on a NAVA ventilator. We heard a little bit about the NAVA level titration procedure yesterday, and that's definitely something to discuss and to develop further. And what we now try to focus on is the second knob available on the ventilator, the PEEP. What we did actually in this particular study is we set up a very simple protocol. Again, we performed a NAVA level titration procedure to identify an adequate level of assist with NAVA. We then used the baseline PEEP level, just a level that was used before by the clinicians, and then increased the PEEP to a high level, which was 20 centimeters of water, decreased the PEEP stepwise to a lowest level of 1 centimeter of water, and went back up again to the high level to just exclude time effects. Each period was applied for about 15 to 20 minutes, and again, in the end of the period, we just collected available data. Now this again, you've seen many of these titration procedures now. That's how it looked like in one of these patients. And in this particular study, we just asked 17 independent physicians or colleagues of us to identify what they thought would be the adequate NAVA level based on the typical shape of the airway pressure and tidal volume curves, and put the red line on there. And what we found is that the correlation between what we used during the study and what they would have used was pretty good. Now this is the summary graph of the titration we performed in this study, and what you can see is that at the adequate NAVA level, the diaphragmatic EMG was decreased by roughly 25%, and at the highest level, the NAVA level at the diaphragmatic EMG was decreased by roughly 50%. Now this is the result of the study put together for the entire group, and first of all what we found is that the tidal volume over the whole range of PEEP changes shown down here remained stable and remained pretty much at the level that was identified during the titration procedure. Now when you think about what happens when you decrease the PEEP from 20 to 1 and up again, that will induce quite a lot of changes in the mechanical properties of the respiratory system. So what the patient did in this circumstances, in order to keep up their tidal volume, they would just have to increase their drive in order to generate more or an increase in the airway pressure above PEEP, which by the end of the day results in the same tidal volume when you decrease the elastance of the respiratory system. So that's what the patient did when we decreased PEEP in general. In terms of the breathing pattern, it was not only the tidal volume that stayed very stable, but also the respiratory rate, and by the end of the day, the minute ventilation. Now again, in this study, we looked at the neuroventilatory efficiency, so this index we talked about yesterday, which is tidal volume over the diaphragmatic EMG. Now this index again reflects the patient's efficiency in converting electrical neuromuscular activity into tidal ventilation. If you generate more tidal volume for the same diaphragmatic EMG, you're just more efficient in generating tidal ventilation. It is important to note that the index does not differentiate between factors involved in regulating neuroventilatory coupling, for example, respiratory muscle and chest wall configuration, muscle force generation, respiratory system elastance and resistance, and intrinsic PEEP levels. Each of these components could be changed by changing a factor such as the PEEP, and the index does not tell you which of the factors actually changed, but it just tells you if the patient became more efficient in his breathing. Now these are the results of one single patient, and again you can see this patient kept the tidal volume very stable. The inspiratory airway pressure just decreased when we decreased the PEEP and increased the PEEP again. But what he did actually with this diaphragmatic EMG is this kind of pattern resulting in an inspiratory airway pressure of PEEP, above PEEP, which looked this way. When we now calculated the neuroventilatory efficiency index in this particular patient, we just found that this patient was most efficient in his breathing at the second lowest PEEP level. And this was true for the decreasing and the increasing part of the study. So this patient was most efficient for the second lowest PEEP level. Whereas this patient here behaved differently. He was most efficient in his breathing at the baseline level of PEEP, so the intermediate level. And the third patient showed here was just most efficient in his breathing with the highest level of PEEP. That's all what the patient did by himself. We did not influence in any way what the patient did. When we put the results together, we just found, and that's now post hoc analysis, that's not a priori defined analysis. We put them together according to their highest neuroventilatory efficiency index and found that some patients had their highest index at the lowest, so one, or at the second lowest PEEP level. Some patients had their highest efficiency at the baseline, at the intermediate level of PEEP, and some patients had their highest efficiency in breathing at the highest PEEP level. So this looks like titrating the PEEP according to the patient's efficiency of breathing might actually help to identify a best PEEP level, at least in terms of ventilatory efficiency. We concluded that increasing PEEP during an adequate level of NAVA assist reduces respiratory drive in general for the entire group. The patients preserve their breathing pattern over a wide range of PEEP levels when they can control the inspiratory assist with NAVA. Monitoring the neuroventilatory efficiency response pattern to PEEP changes allow identification of a PEEP level at which tidal breathing occurs at minimal EIDI costs. Such an approach may prove helpful in individualizing PEEP levels and in minimizing the assist above PEEP during assisted ventilation. Thank you very much.